It's a great pleasure to have Manisha Shah today from UCLA. She's going to be talking about two sides of gender, so about adolescence, intimate partner violence, and a little bit on power. So the floor is yours. Thanks again for sharing this with us.
Thank you. All right. So thanks, Alex. This is very new work, and I think maybe this is the third time I'm presenting this paper. So excited to kind of hear your thoughts and questions. And so please feel free to interrupt me, whenever you have a question. I should also mention that this is joint work with Jennifer Seeger, who is an assistant professor at George Washington University, and also with Marcus and Joao, who are colleagues from the World Bank. And this is actually a project that we started about 6 years ago now. It's a randomized control trial. And the sort of motivation for this project was really this issue of, I guess we often sort of say being an adolescent isn't easy anywhere in the world. You can think back to your own teenage years, but it's particularly difficult right now in the sub-Saharan African context. And, the reason for that is if you look at various sexual and reproductive health outcomes, so for example, teenagers in sub-Saharan Africa have some of the highest unintended teenage pregnancy rates in the world. If you look at where a lot of the new HIV/AIDS infections are happening, a lot of new infections happening amongst adolescents in sub-Saharan Africa. And, and I have the statistic here that 1 in 3 15 to 24-year-olds will experience intimate partner violence. And so the sort of background or motivation for this work was, how do we think about interventions that might improve sexual and reproductive health outcomes of adolescents during adolescence, with the understanding that a lot of these sexual relations that adolescents are engaging in involve power dynamics between the males and the females. And so, if we look at the literature, and I would say this is primarily the literature in economics, but some public health as well, a lot of the previous work, first of all, there just isn't a lot of work on adolescence in economics. There's more these days, but there hasn't been a lot. But if we look in the sub-Saharan African context, most of the interventions that have been, where we've observed positive impacts on teen pregnancy rates or HIV education or even, HIV/AIDS have been very demand side. So, universal primary school education or HIV education or conditional cash transfers in this, Baird et al. Paper. So I guess that's one point. There's been a lot of demand side work. If we think about sort of this unintended pregnancy issue, right? If many of the successful family planning programs across the globe tend to bundle interventions that are both supply side, right, providing contraceptives, as well as demand side, the kind of education piece of it. And a lot of these traditional family planning programs have focused on not only adults, but married adults. And so there's just not been as much focus on adolescents. I think the other interesting thing is if you look at a lot of these programs across the globe, there's just been a lack of involvement of boys and young men in a lot of the traditional sexual and reproductive health programming that we engage in. And I think the last point I want to make about the literature is that most of the causal evidence that we have today in terms of what works in decreasing violence, again, in the economics literature really involves either, cash transfers or some kind of income. And so what we do is we say, hey, given everything that I've sort of gone through, we're going to implement this randomized controlled trial with the ultimate goal of improving sexual and reproductive health outcomes, but sort of thinking about interventions that might help change some of these power dynamics amongst adolescent relationships. Okay. And so let me actually show you this slide and we can just walk through the design quickly. We're going to be working in Tanzania, and we're going, this project will be in collaboration with BRAC, who's, who has a long history now of doing work in East Africa and globally more generally. So we're going to work in their ELA clubs that they have. They have 150 ELA clubs scattered throughout in Tanzania. This will be our sample frame. And what we're going to do is we're going to layer on additional interventions on top of these ELA clubs. And so first we'll have a cluster level or club level randomization. And our control here will be this number one ELA only. So everything we layer on will be on top of ELA. So our control, when I talk about our control group today, think about the control group will be just girls who are getting ELA, okay? We're going to layer on a pure supply side intervention, which is like a nurse from Marie Stopes will come to these clubs every 2 months. Think about this as like a supply side shock in some sense. The nurse will just bring a lot of contraceptives that the girls can access for free if girls want to take them up. And then the other thing that we're going to do is in 50 of these randomly selected communities, we are going to engage the boyfriends of the girls in our clubs in a health-based soccer intervention, which I'll tell you about. And then on top of that, what we will do is we will layer on an individual level randomization where from each of these arms, we're going to randomly select girls to engage in a goal setting activity. Okay, so we're going to have both the club level randomization as well as the individual level randomization. And I will tell you about all of these interventions in 1 minute. And so the research questions that we want to get out of this, something I've been interested in for a long time now. For those of you who sort of know me and know my work, I've done a lot of work my entire career on girls and women. And I've really come to this conclusion that if we want to change a lot of these outcomes related to, condom use, violence, et cetera, we need to get young men and boys involved. And so one of the big research questions that I was interested in is this question of like, in these communities where we're also working with the boyfriends, do we see differential impacts on female sexual and reproductive health outcomes? Okay. And I should mention here that when I talk about SRH, the 3 outcomes that we were most interested in or that we registered were unintended teen pregnancy. We also tested all the girls for HIV and STIs. And the third outcome, of course, is intimate partner violence. And so in these communities where we include boys, yes, we do see decreases in girls reporting of IPV about a year later. Goal setting. So does offering goal setting improve female sexual and reproductive health outcomes? Again, the answer to that question will be yes for IPV, for intimate partner violence. The other thing that I was very curious about was this question about, for adolescents, is it more the like demand side versus the supply side when it comes to contraceptives? And what I will basically show you is there's going to be like no impact of our supply side intervention. And we can talk a little about that. But basically, even though we have this nurse who comes to these clubs every 2 months, the take up of modern contraceptives is just so low. There will be no impacts. And then the other thing that I think, kind of when we started this project, BRAC had given us estimated prevalence of what we should expect when we tested these girls for HIV and STI. At baseline, we test all of the girls and our STI and HIV prevalence, sort of good news for the girls, will be much too low for us to detect anything. And so ultimately, this paper is really going to be a paper about violence and, intimate partner violence. And I won't say too much. I'll show you a little and we can talk a little about what I think went on with the supply side intervention and why, why take-up was so low. But, we won't really say much about disease prevalence. So let me, I guess, break there for a second and see if anybody has any questions before I start talking about the interventions now.
I have a question. So what is peculiar about your population in this case? So how is what is the difference with the average population in Tanzania?
That's a great question. So We're working, I'll show you, actually, let me just show you this map. We're basically working in rural communities in Dodoma, Iringa, and Beya. And so one of the things we've just started looking at actually is the Tanzania DHS to kind of actually, I would like to be able to give you better statistics. I don't have them right now, but really think about ELA. There's other studies on ELA coming out of Uganda. There's actually been other work in Tanzania. These girls are not that different from kind of your average girl in a rural poor community. And I'll tell you a little, the girls that come to ELA are on average 11 to 22 years old. They range, some are currently in school, some have dropped out, some were never enrolled. And really the idea is that they're fairly representative of these poor rural communities in Tanzania. So I wouldn't think about them as kind of different or special, relative to kind of the average girl you would find in these places. And also think about these 150 communities that we're working in as kind of small rural communities. BRAC does run clubs in Dar, for example, but we excluded like these urban places because we wanted to have a very kind of similar sample of rural girls. And I guess just to, think about each club as being on average 20 girls, where, obviously the number ranges, but these are sort of, and maybe I'll just actually show you, this is sort of the inside of a club. And remember, we're going to layer everything on top of these clubs, but really think about these clubs as these fun after school spaces. They're open every day from 3 to 6 p.m. You're expected to show up every day if you're in these clubs. And really what's happening while you're there is there's just a lot of life skills happening, right? You're learning about adolescence, you're learning about reproductive health, you're learning about menstruation, HIV, AIDS, what healthy relationships with boys should look like. And ELA stands for Empowerment and Livelihood for Adolescents. So think of these as kind of empowerment type programs. The older women who are also there, like 18 plus, kind of 18 to 22, they also have access to additional things like, hey, if you want livelihood training, etc. But really the majority of what goes on in these clubs is life skills work. If you look at the evidence on ELA, so like Oriana Bandiera and her team have done a lot of work in Uganda on ELA, and they've found positive impacts on, things like teen pregnancy and income generating activities. But I'll tell you that part of the reason that BRAC contacted me or this study starts is there was similar impact evaluation work going on in Tanzania, this Buren et al. Paper. And in fact, they don't find positive impacts of ELA in Tanzania. And so part of why we start this work is BRAC was interested in, in figuring out how to improve their programming in Tanzania, with the sort of constraints that whatever interventions we thought about needed to be low cost, scalable, easy to implement. So you'll see there's going to be nothing about what we do, which is hey, let's give these girls cash, right? Because BRAC is very much we need interventions that we can continue to scale after you guys leave and they can't afford things like cash, for example. And so that's sort of ELA. Let me now, as I mentioned, the supply side is going to be very simple. You see this nurse here. Marie Stopes, Marie Stopes already visits these places. We just said, hey, can you kind of also visit these clubs every 2 months? And they would bring, Marie Stopes' kind of business plan is very much these long-acting reversible contraceptives. Those are the types of contraceptives that they push, implants, injectables, etc. But they would also bring things like condoms, the female condom, the pill, but just to give you an idea, we did not have a single girl who took up the pill the entire intervention. And these visits happen every 2 months. Okay, so that's our supply side. The boys intervention. So remember, I told you at baseline, we randomly, we basically at baseline, we asked each girl to tell us her current boyfriend. And then in 50 of these communities, we basically gave grassroots soccer a list of names and we said, hey, can you contact these boys for this soccer intervention. And so the boys get contacted. They don't know though why they're being contacted, right? So it's not like we said, hey, your girlfriend told us that you might want to come. There was none of that. It was just like this, we're starting this intervention in your community. Do you want to participate? And in a way, you should think about this soccer intervention is an empowerment program, but for young men. And so let me, they basically, it's a 10-week curriculum. They get together on the soccer pitch, as you can see here. And most of the curriculum is, again, it's around risk behavior, HIV/AIDS prevention, intimate partner violence. And this is just, let me just give you an example, because they just have a really great curriculum. So this is one of the exercises, that they would do one day, which they're on the soccer pitch. They set up 4 cones, where here each cone is a risk behavior. So this cone is unprotected sex. This cone is multiple partners. This cone is older partners. And this cone is sex and alcohol. And so what you have to do, your exercise, is to kick the soccer ball around these cones and not touch the cone, because the cone is like something that you want to stay away from. Each lesson that they do has kind of a key message. And I've written some of these key messages here, right? Like, in life, we should all stand up for girls and women to protect them from abuse, or, build your team with strong supporters that help you abstain from sex, or to practice safe sexual behaviors like condoms, for example. They have activities, like they have this. So in this context, sometimes when girls don't have bus fare, often like the bus driver may say, hey, I'll let you on the bus, if you have sex with me, or there's some sort of transaction involved. So the boys will learn, like, this is a red card behavior. If you see this happening, that's a red card, and you need to like stand up for the girl, because the bus driver shouldn't be engaging in that type of behavior. Okay, so that's sort of the boys' intervention.
Can I ask a quick question, Manisha?
Please.
Just
Yes.
to clarify. So
yes.
These all girls at baseline, did they all have boyfriends? And maybe a second question, and then you can wrap everything at once. So what's the time horizon for the evaluation? Like, were these relationships steady throughout the time, or is this not important for your results?
Yeah, so both great questions.
If I can add to that, just because I had the same question.
Yes.
Whether there are older partners as well. So, and people, of course, that could not be good targets for the soccer intervention.
Exactly. Yeah. So we're working with our ELA girls, and they're kind of ages 11 to 22. And around like 11, 12, 13, 14, like very few of these girls are in relationships, and very few of these girls are having sex. And so what's interesting is, if you look at the data, like, sex really turns on around age 16. And then kind of, if you look 16 and up, like almost everybody is having sex or in some kind of relationship. The relationships can be very fluid. And I'm actually, we're going to kind of build a model, and I'm going to walk through some of the mechanisms of like what we think is going on with these violence results. And one of the things I will show you is that there is like churn and sorting that goes on. And so, let me hold off a little on that. But yes, you should definitely think about these adolescent relationships as fluid, because this is one of the things that will model very differently. Like, if you look at a lot of models of violence in economics, I think often like the participation constraint of like, hey, I'm just going to leave, is much harder if you say you live in a household with a husband, you have children, and your husband beats you. You're much less likely to just kind of leave, because your outside option, doesn't look as good, or maybe, whatever. But I want you to think about these relationships as a lot more fluid, precisely because they're teenagers and they can kind of come and go a lot more. In terms of the age gap, yes, there is the average age gap between our girls and their boyfriends is around 5 years. And one of the things I will also show you is that is something that shifts at end line. And so the, you know, as I'm sure many of you know, the larger the age gap, the kind of worse the outcomes for girls generally in terms of risk behavior. And one of the things we're going to see is that's going to go down, in fact, by about half a year. Okay. And then, you know, remember I told you we layered on this sort of individual randomization where we selected girls to participate in this goal setting activity. And what's a little, you know, what's a little strange, or what I will tell you, is that goal setting decreases IPV, because there's nothing about our goal setting activity that we do that centers around intimate partner violence. You know, when we thought about this intervention, I was very interested, you know, 5-6 years ago, there were interesting results coming out of the South Side of Chicago, where they were working with like low-income youth, basically teenagers there, around education, and finding, you know, really interesting impacts around goal setting for like test taking and studying. And so we thought, hey, we're also basically working with low-income teenagers. You know, goal setting is about self-regulation strategies, problems with self-control, present bias. These are all also very associated with kind of sexual and reproductive health choices that teenagers make. And so what we do, you know, we basically very much follow what others have done, and we adapt this SMART strategy that's often used in cognitive behavioral therapy. You know, where the idea here is you need sort of specific, measurable, achievable, relevant, and timely strategies in order to meet the goal. And so we set the goal for the girls, which was like, hey, your goal from like now till we come back a year later is to stay healthy and remain STI and HIV negative. And it was like, is this a goal you want to work on? And if they said yes, and basically like almost all the girls who were selected for this agreed to say, yes, this is a goal I want to meet, then we did like a 60 to 90 minute exercise individually with each girl, which was basically like, okay, you need to write down 0 to 3 strategies that you are going to engage in to achieve this goal. And, you know, you can figure them out on your own. Like, we're not going to tell you what the strategies are, but we want you to write them down. They had a worksheet. And then we want you to think about, like, what are some of the behavioral things, you know, like, say your main strategy is I'm going to use a condom now every time I have sex. Like, what are some of the things that will make it difficult for you to do that? And how will you deal with those difficulties, right? Sort of what will your coping mechanisms be? And so it was a pretty like in-depth exercise. We came back 4 months later and just, you know, we had everything on a tablet. And so it was like, hey, you know, you said 4 months ago you were going to be engaging in these types of behaviors. How is it going? Blah, blah, blah. And that was basically it. Like, that was our goal setting. And then, of course, you know, we came back at end line and tested all of the girls. And I will tell you that I was a bit like, when we had first thought about goal setting, I had wanted to pair goal setting with some sort of incentive as well. But as I mentioned, BRAC, you know, they didn't want us giving the girls money. And so I wasn't sure this was actually going to be effective. But you know, I'm going to show you some pretty interesting results. So this is just to give you an idea of the types of goals the girls are setting. Our 3 main goals are: use a condom is number 1, be faithful is number 2, and abstinence is number 3. And you'll see here that there's a big difference. You know, we're kind of looking more into this data, but like for the girls at baseline who are already sexually active, they're sort of thinking about like safe sex strategies. And these are going to be a lot of the girls at baseline who aren't sexually active, who will be like, hey, I'm not going to become sexually active for, you know, for longer. And so looking at the impacts is a bit complicated, because you sort of have these like 2 types of girls, like those who are already having sex and those who aren't. And in fact, I will show you some interesting heterogeneity by these groups. This is just to show you some correlations that, you know, for us, it was also just a sanity check of like, does this data make sense? And, you know, so we had administered the PHQ-2, which is a depression screen at baseline and end line. And so what I think is interesting, you know, I mentioned girls can set between 0 and 3 strategies. And so girls, for example, who are depressed, are setting fewer strategies. Girls who rank higher on this self-efficacy measure that we also borrowed from the psych literature are setting more strategies. Wealth, if you're the sort of poorer you are, and I should say all of these girls are poor, but the poorer you are, the less strategies you're setting. And this is at Endline, we asked them how many strategies did you achieve? And kind of similarly, I think it's really interesting, right? Girls who have higher self-efficacy are saying they're achieving more strategies. Girls who are depressed are doing less of that. And this is just, again, some more correlations to show you, like, these are measures of sexual behavior at Endline. And we were just, again, we were curious based on the strategies that you set. So these are girls, who said they were going to abstain. And you will see at Endline, girls who said they would abstain during, our first goal setting exercise are around 7.5 percentage points more likely to, say they're not having sex at Endline. Girls who said they were going to use condoms, that their main goal was to use a condom, are like 9 percentage points more likely at Endline to actually report to us that, they're using a condom with their last partner. So it does, I guess all of this was both to convince myself, but hopefully to convince you that it does look like this goal setting exercise did sort of impact these girls' behaviors. All right, let me stop there and see if there are any questions before I move on.
I would have a comment. So, so these correlations that you have shown are basically people, self-reporting strategy and self-reporting behavior.
Yes.
So, and specifically the strategy on condoms would lead us to think that condoms are important. So how do you reconcile that with the fact that you don't find much on the supply side?
Oh, you mean why am I finding that these girls are more? So I'm going to show you this, like this will be at Endline. What I'm going to show you is the girls in the goal setting arm are actually, so the most churn that we're going to see, or the sorting that happens, will be that the girls find new partners at Endline, the girls who were assigned to goal setting, and they report that their partners are more likely to use condoms. So I'll get to that in a minute. And that's actually going to be an important mechanism for what we do. Any other questions? All right. So this is our timeline. It's a 2-year study. I mentioned we've been working on this for 6 years, but we were in the field for 2 years. So we did, this is the sort of the census of all the ELA clubs. We do our baseline, we do our testing, and then all the interventions start. And we basically, come back and do our Endline 6 to 8 months after everything is done. Okay. So, think about the interventions happen, time goes by, and then we come back and collect our data. And this is just to show you some means of our main outcomes of interest. And this, this goes back to this question of, so this is the full sample, all of our 11 to 22. And then these are the girls who were already sexually active at baseline. And you'll remember that I gave you that 1 in 3 will experience IPV number. And so this is from our data. Have you experienced any IPV in the last year? And you'll see that, the big difference, right? If you're sexually active, 27% of girls experience some type of IPV in the last year, relative to 8% if we're looking at the whole sample. Our IPV measures, we basically, the way we asked this in our survey is we borrowed from the DHS. And so the DHS kind of breaks into psychological, physical abuse, and then forced sex. And we will do the same thing. Mostly what I'll show you though is, because we have, we have multiple sort of dependent variables related to violence, I'm going to construct a summary index. And basically, just use the summary index to show you impacts, but it'll be sort of IPV in the last year, which will be psychological, physical, and forced, and then it'll be IPV often. And so think of this as kind of the more frequent measure, and then this is more the longer term measure. you'll see that, you know, pregnancy rates are high, right? So 47% of our girls who are already sexually active at baseline have at least been pregnant once. And then these are our, you know, baseline testing rates, as I mentioned, very low rates of both STIs as well as HIV. Okay. And I, you know, I'm not going to spend too much time on this, but this is an RCT. And so obviously we were worried about like balance issues, and we're very well balanced, and we have many tables in the paper, and I'm sort of happy to, we finally have a draft of the paper. So I'm also happy to share that if anyone wants to see more of that. Okay, so you know what, basically all of the results that I'm going to show you today, I'm going to estimate models where we have everything. So we're simultaneously estimating intention to treat DD estimates. And the reason that I'm going to use we're going to use the balanced panel. And the reason I'm going to use the balanced panel for all of these estimates is I'm interested in the, you know, the causal impact of being assigned to goal setting. You were only able to be assigned to goal setting if you showed up in our baseline data, right? Because we randomly selected girls from baseline to engage in goal setting. And so even though we have like we have 2 repeated cross sections where we, you know, we interview every girl in these clubs at baseline and end line. Today, the results I'll show you will be girls who were at end line who also show up at, who were at baseline who also show up at end line. Okay, because I'm really, and also, you know, I'm interested in this beta 3. I'm going to show you, you know, basically I'm going to show you some figures where we're going to graph beta 1, beta 2, and beta 3, which will be the, you know, the ITT-DD estimates of interest here. Beta 1 will be, you know, the average effect of being assigned to the boys arm. Beta 2 will be the, you know, the average effect of being assigned to the supply arm. Beta 3 will be the, you know, the average effect of being assigned to goal setting. What else do I want to say? We'll have club fixed effects. Everything I'll show you today, standard errors, will be clustered at the club level. And so this here, this is basically what this is our 2 dependent variables here. This is our IPV often index. This is IPV in the last year index. And so what this is saying is that if you're a girl assigned to the boys treatment arm, where the boys treatment arm is the soccer arm, at end line, you're reporting about a 0.162 decrease, 0.162 standard deviation decrease in experiencing IPV often, and about a 0.12 standard deviation decrease in experiencing IPV in the last year, okay? And so that's our beta 1 for, you know, that's our beta 1, and then our beta, I guess this is goal setting is beta 3. So this is our beta 3, same regression. And here you'll see the estimates are very similar. So for girls who were assigned to the goal setting intervention, they're, you know, again, very similar, around a 0.13 standard deviation decrease in experiencing IPV often, and about a 0.113 standard deviation decrease in experiencing IPV in the last year, okay? This is our beta 2, which is the supply side, and there's just nothing going on. And you might think, hey, well, why should, you know, bringing contraceptives decrease IPV? I think that's a fair question. Honestly, we were hoping that it was going to move this pregnancy index. You see nothing. So basically, this is still our beta 2 for pregnancy as the dependent variable. There's just absolutely nothing going on, nothing in our supply arm, nothing. And I just want to show you why. Yep.
Manisha, one question.
Yeah.
So all of the surveys were just performed with the female sample, or also with the boys?
That's a great question. So we also, in all of these communities, we did sample some of our boys, the boyfriends, and I will show you some data for the boys. Yes. Okay. So we have boys. It's a much smaller sample. It's about 2,000 boys, but I will show you some results from them. Yes. So this is just to quickly show you, so Marie Stopes really pushes these like injectables and implants. And so you'll see at baseline, maybe like 1 or 2% of girls are using injectables and implants. And column 2, right, this is where you would expect to see a big increase because Marie Stopes is coming. And you'll see that like just nothing moves, okay? We go from like 1% to 2% of our girls using implants. And so they're just not taking up these modern contraceptives. I think what is interesting though is that, the sort of contraceptive, for those of you who are interested in this, the contraceptive of choice really is condoms. And you'll see at baseline, right, 12 to 15% of girls are using condoms. You'll also see that this increases a lot by end line. And part of why this increases a lot is we're 2 years later. So a lot of girls have entered sex 2 years later. But it's really kind of, there's no differential impact, right? It's not happening more in the supply side arm. It's just that this is what girls are using, or I should say what their boyfriends are using. And so this whole idea of like bringing them these modern contraceptives and there's going to be huge take up, like I really think these types of interventions need to, I guess what I'm trying to say is there is a reason we do demand side and supply side for these like successful, family planning type interventions. And it wasn't enough to just bring them these things. So with that, I'm not going to say too much else about the supply arm. It will always be there in the estimation, but we're not going to focus on it. Yes.
Yeah, sorry, can I ask you a question about this use of contraception? Have you thought about investigating also the reaction of the parents?
Yes.
To this use of contraception?
So this is a great question. And in fact, obviously, this is a study where you need parents' consent, and we did all of that. But you're absolutely right in that once these nurses started visiting the clubs, there were many communities where parents were not happy. And in fact, BRAC had to do some outreach during this period in these communities again to be like, because the parents were sort of like, what, you're bringing these contraceptives to the girls, like, even though they had sort of, I think it's one thing to kind of tell them it's going to happen and then it happens. And so there was definitely, I think some, yes, like I do think like the parents, maybe chilling factor because of the parents' backlash. We don't have a good sense of like, I can't tell you like why take up was so low, but I definitely do think like if we were to do something like this again, potentially getting parents involved might be a good way to get more buy-in, for example. We did this in the clubs because when we were doing exploratory work, a lot of the things the girls told us was like, hey, we would use modern contraceptives more, but it means like I have to go to the pharmacy and like, the pharmacist knows my mom and everybody knows me at the pharmacy. So it's too embarrassing. And so we thought by bringing to the clubs, there would be kind of less stigma, less embarrassment. But, again, it wasn't terribly effective.
Okay, thanks.
So then, we do some heterogeneity by whether you were sexually active at baseline. And we do this also by age in the paper. But what I want to show you is like, I think it would be fair for you to say like, hey, a 0.1, 0.2 standard deviation decrease in IPV is not a huge impact. And so now what we're doing is we're re-estimating our models with the sort of had sex heterogeneity. And what you'll see, what this is showing you is that for the girls who are assigned to the boys soccer arm, who are sexually active at baseline, these girls are observing about a 0.5 or experiencing a 0.55 decrease, standard deviation, a decrease in IPV often, okay? And so these results are like much larger for the girls who are sexually active at baseline. Same thing for the goal setting arm. So, we can look at, this is the interaction of, you were assigned to goal setting and you were sexually active at baseline, about a 0.3 standard deviation decrease in IPV often. Okay, and so, I could show you very similar figures for like age, I think we look at age 17, same thing, just much bigger impacts for like the older girls and the more sexually active. Okay, and so.
Manisha, oh, sorry, can I ask a quick question? This is going back a few slides now, but I think it's related to what you just said, which is you found that the boys treatment reduced intimate partner violence, but also reduced the number of partners, I think, or reduced the likelihood of having a partner, if I remember seeing that graph right. Is it, I mean, like if you, I don't know what the econometrically kosher way to do this is, but like, can you condition on like having a partner? I guess my question is one of the ways these girls are avoiding violence is by just not having a partner at all?
Yes. So that's a great question. And the answer to that is some of the girls, yes. And I'll show you that in a minute. And so, and I guess before, you know, what I want to do now is kind of move on to show you we've built a little model to try and understand everything we've found so far. But before I get to that, I guess let me just, you know, quickly open it up again. If there are any other questions, I'm happy to take. Those are sort of like the main, you know, reduced form RCT results. And now really what we want to do is we want to develop a theoretical framework to help us think through some of the mechanisms of, you know, what's going on here, right? Where in these communities where we include males, we see a decrease in IPV. Also in these places where, you know, we engage girls in goal setting, we observe this decrease in IPV. And the other sort of main, I think, interesting empirical finding from this work is that the effects are much larger for these females who were already having sex at baseline. And so what we're going to do is basically build a small model of, you know, of kind of sexual behavior and think through what some of these mechanisms are and what's happening.
Can I ask a question about measurement of IPV? So,
yes.
Could you please tell us a little bit about how you measured? And so this is so have you thought about measuring these? So through asking about other people, so not just relying on self-reports.
Yeah. So. We basically, the survey, the way we asked the violence questions to the girls was how the demographic health surveys do them, the DHS surveys. We basically borrowed from them. And we asked them directly. So if we did like, you know, there's a lot of people right now doing like list experiments and vignettes, and we didn't do any, we just sort of directly asked them. I will say though, you know, we did these surveys one-on-one. So there was a lot of emphasis placed on make sure you're like with these girls privately, you know, so that other people aren't around. One thing we didn't do though, that we don't have, so these are measures of violence with their, you know, with partners. We don't have any other measures of like, hey, do you experience violence like in your household, for example, right? Because there is a high correlation, right, between like you grow up in a violent household and then you end up with a violent boyfriend, for example. So, you know, we don't have any of that. We also honestly, like, we didn't do a great job on like measurement of things like social norms in these communities, right? So, you know, I'm going to show you some of our boys' data to potentially get at some of that, but really you should think about these as sort of, these are girls, you know, experiences of IPV in these relationships with boys. And we don't have much else though in terms of measurement on other types of violence or more kind of around like social norms around violence. We just don't have a lot of good data on that. Okay, so in terms of thinking about our model, you know, we looked at a lot at the sort of literature on violence. And if you look at this literature, there's really two motivations for violence. There's sort of this instrumental idea where like men will use violence as a tool, right? And it's a tool for controlling behavior in order to be able to extract resources from their female partners, right? It's sort of, I am going to use violence on you to kind of get what I need, whether that's resources or consumption or, you know, whatever that sort of instrumental thing is, versus the more like expressive, you know, motivation for violence, which is just this, you know, basically this idea that I get utility, you know, from engaging in violence with you. And so there's some source of gratification, whether it's through like direct utility effect or an irrational impulse. But I think, you know, regardless of which world we're in of motivation, I think both of these motivations point to a potentially important role of learning, of socialization in explaining why men perpetrate violence against their female partners. Okay, and hence the potential promise of educational interventions like grassroots soccer, for example. And so what we do is we, remember, we want to understand the mechanisms through which soccer and goal setting can impact IPV. And so we need to build some sort of model that's going to explain both of those things. And so what I've set up here is this is just a utility function. And this is going to be, we're going to have a utility function for the boy and the girl, the male and the female. And it's going to be kind of the utility you're getting from like this relationship, think about that. And it's going to be a function of H, which will be, health, S, which will be, risky sex, and V, which will be violence. Okay. And so I want to say a couple things about this now. One is all of these things are 0, 1. So you're either in a world where violence happens or it doesn't, right? It's a 0, 1. In terms of like risky sex, the idea here is that we all like risky sex, males and females. So delta U, delta S is positive. Of course, we also all like good health. So delta U, delta H is positive. But we like risky sex, hence positive, but there's a cost to risky sex, right? In that, you may engage in non-condom sex, but then you have some positive probability of getting HIV or getting an STI. And so there's this cost here, which delta H, delta S is negative. And so the idea here is that you are going to be willing to engage in risky sex if we know this term is positive. We all like risky sex, but this term is going to be negative because of this, delta H, delta S term. And so if pi is greater than 0, you'll engage in risky sex. If pi is less than 0, you won't engage in risky sex. Okay. And so what I'm going to tell you now is like in a world where there's no violence, if both the boy and the girl like risky sex, so the pi male and pi female is positive, that's fine. There will be risky sex, no violence, etc. In our model, the idea behind violence here is that violence is going to have an instrumental role for the boy in that with violence. So in this world where they disagree, right? In the world where the boy wants risky sex and the girl does not want risky sex. So this is the world where pi m is positive, pi f is negative. This is an example where the boy can engage in violence for an instrumental reason, right? He wants to kind of extract risky sex from his girlfriend. And so he's going to engage in violence in order to kind of get her to engage in risky sex. Okay. And so in this world where there's disagreement between the boy and the girl in terms of risky sex, what we can do, all this term, this number 3 here is I'm differentiating the utility function with respect to V, and I get this term here where delta U, delta V is just going to be like the direct, think about this as the direct utility you get from violence, okay? And we're going to assume that delta U, delta V is negative. It's an easy assumption for girls that this is negative, right? Because, you may have their psychic costs from, getting, bruises, physical, et cetera, et cetera. We're also going to assume though that delta U, delta V is negative for boys in that, so in our model, boys are really going to use violence instrumentally in order to get risky sex, but they're not just going to kind of engage in violence because they get like direct gratification from it. Okay. And then this term will be our pi, which we already talked about, but this term here is going to capture this sort of indirect or instrumental, whether it's utility or disutility from violence piece of it, okay? And the boy as well as the girl will have some participation constraint, right? In that, obviously you're only gonna stay in this relationship if the utility from staying in the relationship, is better than like, say she could obtain if she were to leave the relationship. And this piece of it, I think is as I mentioned earlier, it's kind of easier for adolescents to walk away versus this participation constraint. Like if you were a woman in a marriage with children living in a household where your husband was beating you, for example, right? And so the idea here, though, is in equilibrium, the boy will choose whether or not to engage in violence to maximize his utility, subject to not violating the girl's participation constraint. Okay, and I will show you that in the goal setting arm, you will see girls kind of leading relationships. Okay, so what I want to do now, so this is like sort of our simple model, but what I want to do now is I want to think through our interventions and really tie them back to the model. And I'm going to start with the grassroots soccer arm because I think it's an easier, it's pretty easy to think about how grassroots soccer might, you know, result in decreases in violence. And so they're sort of like, you know, the soccer curriculum itself, like a lot of what the soccer curriculum is trying to do is reshape boys' attitudes towards IPV. You know, I showed you some of the like key messages and you know, the curriculum. And so really you can think about GRS as also basically shifting this delta U, delta V term, which is this first term here, right? It's kind of just like how much utility I get from engaging in violence. And in theory, if you go through grassroots soccer, you probably will get less utility from violence after you've done the curriculum, or at least that's their ultimate goal. Having said that, though, the soccer curriculum also does a lot about teaching boys about sexual and reproductive health more generally, right? They do a lot on like HIV/AIDS and risk behavior. And so here you could think about GRS also as really impacting that delta U, delta H term, right? Like how much utility I get from good health. And if I now value my health more, you know, thinking back to that pie term, right? My pie, you know, I may now start valuing risky sex less. And I may want it less because I'm sort of like, hey, now I get that, sure, I might really like having sex without a condom, but the possibility that I'll get an STI goes way up when I have non-condom sex. Okay. And so again, like grassroots soccer has the potential to also be shifting this term here through its curriculum. And so GRS, I think in some sense, GRS is easy because both of these channels would, you know, unambiguously predict reductions in violence. This channel will also predict reductions in sexual activity, right? And kind of less risky behavior, precisely because the idea is now I value my health more, maybe I value risky sex less, okay? And so now I want to take these things to the data, exactly. But before I take them to the data, please ask me some questions.
So these predictions, if I understand correctly, they would be exactly the same if instead of a soccer curriculum would be just a training or just a standard training. So do you do something in this framework to understand whether it is important explicitly the fact that they play soccer, so which can be, you know, a group activity, or it can also be a release of violence, for example?
Yeah, so I think that's a great question. I don't have an answer for you besides to say I've been trying to like sell to grassroots soccer that we should do something again where like in some schools you just have boys playing soccer, and then in other schools you have boys playing soccer plus their curriculum, right? Because I don't, you know, there's no world in which I have just like a pure soccer thing versus, you know, versus soccer plus curriculum. Having said that though, you know, one of the things I will show you is that when we go back 6 to 8 months later, the boys in this arm, you know, I haven't shown you the boys' data, but what I will show you is the boys in this arm are spending less time with their girlfriends, and they're actually still spending more time in sports. Like they're still playing soccer 6 to 8 months later, even though like grassroots, the curriculum has ended, they're not, you know, and so I think there's definitely something about the group activity and the network and the like doing this together that matters. But empirically, I think it's absolutely a fair point that like if, you know, I can't distinguish between like the soccer and the curriculum because they're doing both of these things together. They would tell you, though, that it's very important to do these things together, because part of what they're trying to do is exactly this idea of like shifting social norms. And so you work with these boys while they're young. You're working with them as groups of boys with the idea that, you know, there's going to be this kind of social thing that happens over time. But, you know, this is sort of what they sell. I'm not going to be able to show you any of that, but I think that's a fair question. Anything else before I show you some of these predictions?
Yeah, can I ask another question on this slide? You talk about how the predicted derivative or the predicted effect of soccer intervention on health is that like it makes the boys more conscious of the risks of unsafe sex. But I mean, like, given the really low means of STIs you showed us, like, is it possible that like making the boys and the girls more conscious of all this like could help them realize that like the risk is actually very low and have the opposite effect?
So I think yes, like, I mean, let me say we didn't tell them, like the boys don't actually know, like none of them were given this, you know, the girls, you give the girl her information about like, you have nothing or whatever, but like, it's not like we shared to all of them, like, hey, you all, like less than 1% of you tested, you know, positive for an STI. So potentially, like, I don't think that's happening in this context just because they don't know. I will also say that it's not clear to me, you know, we didn't test any of the boys. And so I've shown you like the STI results for the girls ages 11 to 22. I don't actually know what the boys, you know, look like in this context. I'm assuming their rates are higher just because they tend to be higher. But yeah, I don't know. Any other questions? Okay. So now I'm just going to show you, you know, so just to kind of recap, boys soccer, we have this delta U, delta V, and if delta U, delta V is shifting, we would expect to see them in, you know, maybe their attitudes around violence shifting, maybe they're engaging in less violence. And then of course, there's the second piece of it where their indirect utility is falling. And here we would see less sexual activity, less risk behavior, maybe less partnerships. Okay. And so this now, I was asked about the male data. So this is now, when I show you results using the boys data, because this gets a bit confusing, I will always have like male data in parentheses just to distinguish. And so what we did is, you know, we did interview boys in each of these communities. So these are also DD regressions, where now though, you know, we are looking at boys. And so what this is, you know, boys assigned to the boys treatment arm. So these are also like ITT, you know, you're assigned to the boys treatment arm. What goal treatment here means is that your girlfriend was assigned and got goal setting. Okay, so that's what goal treatment means. But let's focus on column 1 here. So, you know, we asked boys all sorts of like violence attitude questions. And so this index, what this is showing you is that boys who are assigned to the soccer arm, their attitudes around violence improve. So they're like 0.2 standard deviations less likely to, you know, to kind of think that violence is okay. Basically, you know, like we have questions about tolerating violence and men beating women, etc. We also asked boys the same exact questions that we asked our girls about IPV often and IPV last year. But instead of boys, you know, experiencing it, we asked them, do you perpetrate? Here, I would say this was tough because basically, like, it's hard to ask boys these questions and like, we get nothing. And like, you know, very few of them report to engaging in these types of behaviors. But one thing that's interesting is we added this additional question onto the boys survey, which is like, hey, you know, like sometimes when you're drunk, or, you know, there's very little drug use, but there is alcohol use. So sometimes when you're like, you know, you're under the influence, do you sometimes hurt your girlfriend? And here, you know, around 2.5% of our boys do engage in that behavior. And you'll notice that there is a decline here, right? So it's pretty big. I mean, like 3.8 percentage point decrease of, you know, being assigned to the boys treatment arm, saying you're less likely to engage in this behavior. And so it does look like there's something shifting, at least in attitudes. maybe something in behavior. It's hard to say, but it does look like that delta U, delta V is shifting for the boys assigned to the soccer arm. Okay. This is another, you know, we asked them about like, do you think girls have a right to ask, you know, you to use a condom? And again, if you were assigned to the boys arm, you're 10 percentage points more likely from a base mean of 80% to say, yeah, girls should be able to ask to use condoms. We also, you know, so this kind of, think of this as the delta U, delta V. This is now the less partnerships, less risk behavior, et cetera. We look at the, you know, we create this partners index, which is a lot of these, you know, kind of, do you have a partner? How many partners do you have? Frequency of sex? And you'll see that all of these things are negative in the boys' soccer arm. Like nothing is statistically significant. Like everything is negative though. And we have these same dependent variables in our girls survey data. And I think what's interesting, and so these are all the same dependent variables, but now we're back to the girls data. And you will see that in the girls in the, you know, assigned to the boys arm are reporting less kind of overall sexual activity, you know, less likely to have multiple partners, spending less time with boyfriends. And then this is, you know, I think there was this question about like, so this is all girls. This is conditional on having a partner both at baseline and end line. And so you'll see that this is both like, for some girls, it's like they're, you know, just not having partnerships. But even for girls who are in partnerships at baseline and end line, they're spending like less time with their boyfriends, they're having less sex. And so it does seem like some of these sexual behaviors have shifted in this boys treatment arm, like as based on kind of data from the boys as well as the girls. What else do I want to say? I think, and so, you know, this is just, I think like one thing that's interesting. So this is back to our, you know, our boys data. We at Endline, we asked boys who are in partnerships, you know, things like contraceptive use, et cetera. So it just, again, this is just to kind of show you, it does look like there's like less sex happening and possibly safer sex happening in the boys treatment arm. Okay. And so that's sort of the grassroots soccer piece of the model and the predictions. And so it does look like both kind of the delta U, delta V term is, you know, that like boys are getting less utility from violence, as well as that like the indirect instrumental reason for engaging in violence is also going down through grassroots soccer. Let me now move on to goal setting, unless there's questions about the boys' results. So, all right, I'm going to keep moving. You know, the goal setting arm is a bit harder, right? Because there was nothing that we did in goal setting that was explicitly around violence, right? There was absolutely nothing we did around violence in goal setting. And, you know, so kind of just to remind you, like the goal setting exercise, the idea was to kind of strengthen girls' commitment to adopt safe sexual behaviors with the ultimate goal to remain healthy, to remain STI and HIV free. And so here, where we should see movement, right, is we're ultimately trying to increase her utility that she gets from health, right? So her delta U, delta H, and also to decrease the utility she gets from engaging in risky sex. Theoretically, though, this could increase or decrease violence, right? And so the reason that this could potentially increase violence is, remember, in our model, boys are using violence instrumentally to get risky sex. And so prior to goal setting, maybe the girl, you know, her pi F was positive and she also liked risky sex. So both pi M and pi F were positive. Both the boy and girl like engaging in risky sex. The girl then engages in goal setting and says, hey, you know, my goal that I've set is that I'm going to use condoms. And so, you know, I'm no longer going to have risky sex with you, and we need to use a condom when we have sex now. In that world, this could increase violence, right? Because there could be a backlash effect where now the boy's pi m is still negative, the girl's pi f is positive, and now he, you know, this is basically going to trigger a violent response from him as an instrument to force her to continue having risky sex. We can rule this out in our data. We don't see any of this because we only see, you know, the kind of number 2, which is the decrease in violence. And here, basically what the model predicts is you would see a decrease in violence because her utility from health is increasing. It's also causing an increase in her indirect disutility from violence, right? That is used as a means to force her to engage in risky sex because she is now less likely to want risky sex. And so this could also trigger the participation constraint, right? The relationship could dissolve for her because she decides to leave and either potentially sort into a healthier relationship or potentially sort into no relationship, right? But that this could sort of trigger her participation constraint. And so what I'm going to do now is basically look at some of these issues, and you know, we want to look at some of what's going on here with number 2. And so the first thing I'm going to show you is this table, which is, you know, at Endline, we ask girls to tell us about their current partnerships. And so these are girls who, you know, this panel A is ever a sexual partner and panel B is current sexual partners. And the characteristics that we were most interested in are like characteristics that are highly correlated with risk behavior, right? So if you look at the literature, we know like the higher his age, the kind of worse for the girl in terms of like risk outcomes. We also know education is highly correlated with risk. We know that, you know, we're interested in contraceptive use. And so what I'm going to do is I'm going to build this, what we call the quality index. The quality of your boyfriend is going to be a function of like his age, his education, and contraceptive use. And so I think like one of the kind of really interesting things we're finding is that if you're assigned to goal setting, at Endline, the quality of your match has increased by around 0.17. You know, the quality of your current match has increased by around 0.17 standard deviations, okay? The guys have gotten younger. You're now matching with boys who are around half a year, 0.6 years younger than they were at baseline. You know, they're less likely to be out of school. They're more likely to be using contraceptives. And so it does look like there's kind of some resorting going on where goal-setting girls, at least some of the goal-setting girls, are finding new boyfriends who are higher quality at Endline, okay? And so this is the kind of participation constraint story being triggered. This, you know, I already showed you this table. We looked at sexual behavior for girls who were assigned to the boys treatment. What's interesting though, is that girls who are assigned to the goal treatment, they're not, so none of these things are negative, right? So it's not like they're having less sex. If anything, they're actually having more sex. But I think what's interesting, and again, if anything, they're having more total sexual partners. And the reason for that is precisely because of this kind of sorting that's going on and rematching that's going on. Okay, so it's not that, you know, there's necessarily less sex happening, but they are matching with new boys at Endline. And then the other thing, you know, we also, you know, because we have all this information at baseline and Endline on, you know, on partnerships. I think the other result I really want to show you here is that this is this question of from like baseline to Endline, are you still only with what old partners means? And I guess old is used badly here because it's not age, but it's like, are you with the same guy that you were with at baseline? And again, you'll see that girls who are assigned to the goal setting treatment are 4 percentage points less likely to report, you know, from a mean of around 12%, that they're with the same partner that they had at baseline. Okay. And so this gets to, you know, I think, you know, we were talking in the beginning about like how much like sorting or, you know, is happening. And it does seem to be that like there's some movement there or you know, changing of boyfriends for girls who were assigned to the goal setting arm. And so I think like the kind of interesting piece of this is that in a way, the like decrease in IPV, I mean, for us, it was unexpected. because it wasn't really a part of the actual goal setting treatment, but it's coming through the fact that we're sort of encouraging these girls to adopt, whatever safer sexual behaviors that they need to be adopting to reach their goal. And because of those goals, they're sorting to higher quality boys. And because they're sort of sorting to these higher quality boys, you're seeing violence decreasing. We're actually looking at the data right now. And I just want to say, it's not like all of them are sorting. So for some of them, what you see is they actually stay with the same boyfriend, but at baseline, they had violence, and at end line, they don't. And so here it seems like, basically here, maybe, thinking back to our model, maybe the girl is sort of like, hey, I'm going to leave unless you change behaviors. And the boy actually does change behaviors, right? Like maybe there's some changing there going on.
Can I ask a question, Manisha?
Please.
If I recall correctly, the picture you showed at first with the design, there were girls that were given this girl treatment that were matched with boys having the soccer. So did you find anything at this intersection?
Yeah, so great question. I will get to, so exactly, we were interested in complementarities, right? Like, so if you're in this arm where, boys are all getting treated and you're getting goal setting, like, do you see bigger decreases in violence? We do not. And I'll actually show you the results in a minute. I think one of the reasons we don't is because this is still like a relatively low violence setting. And in a lot of our indicators, we're almost moving them down to 0. So like, we're really, we're at kind of a mean of 4% and we're getting around 3%. So there's not that much more like room to move these things. I think that's part of the issue. And so I think one thing that would be really interesting is to like redo this in a setting where like violence rates are much higher, because my sense is maybe then you might get some of these interesting complementarities that we're just not seeing.
Can I ask a question, Manisha?
Yes. Yes.
For those who stay with the same boyfriend and experience reduced violence, should we be worried about maybe some cognitive dissonance avoidance? So I set these goals. I spent the past month thinking that I will improve my situation, and then it doesn't. And when I'm asked why I stayed with the same, whether I stayed with the same boyfriend, so I'm trying to figure out a story, and I'm lying to myself and to the experimenter.
Right. I mean, I think that's a fair point. I will say though that when we go back at end line, like, remember, everything has been over for a while and we're just asking girls like, hey, who's your current, so all of this is just done. The data work is done through matching of names from baseline and end line. So it's not like we're sort of priming them about like, these were your goals, or remember you did this, or this is very much just a survey of like, who's your current boyfriend, name, how old is he? Does he use a condom? And so it would really have to be the case, right, that she's kind of putting these two things together, which, I can't reject is not happening. But I don't know how much of that, is happening. Mm-hmm.
Thank you.
Any other questions?
So, related to this, to the relationship between these two interventions, so would it be possible, maybe you didn't ask the question, I don't know, to check whether people in the goal setting, they are moving to boys that were actually part of the soccer intervention? Because as you're telling the story, the boys in the soccer intervention are the initial boys, are the initial boyfriends. And if there is change, it seems a bit, so I don't know, what's the story that you can tell with respect to that?
So I can't, okay. So actually let me So I think this, I'm not exactly going to answer your question, but let me tell you one of the things we were worried about, which I think is related to your question, which was like, we're seeing churn happening of girls who do goal setting, right? Like some of them are leaving their violent boyfriends and finding new boyfriends. You worry about general equilibrium effects because these are small villages. And so is it the case now that you kind of have like other girls who are pairing with these like lower quality, like bad boys? So one thing we've looked at, and, you know, happy to hear more about what you'd like to see, but in these communities, we looked in our ELA only communities, right? These are our control communities. And so we look in our control communities because we have, you know, girls who did goal setting and girls who, you know, didn't, and there were no other interventions going on. And so the sort of only GE thing we've looked at so far. So we were concerned, right? So this is, you did goal setting, you're in ELA only. These are our non-goal setting girls. And we were concerned about the offset here, right? That this decrease in violence, but then for the girls who didn't do, you know, goal setting, you'd see an increase in violence here because they're now matching with these like lower quality boys. You don't see that offset happening, right? Like there's not some big increase in violence for the girls who didn't participate in goal setting in our control communities. And so we're not worried about that. But you're asking me now about girls in soccer communities. So ask me your question again. I just want to make sure I understood it. So
I wanted to, so if I understand well, so what's happening here is that people in the goal setting, these girls, are changing boyfriends to safer people.
Yes, yes.
I wanted to get a sense, I mean, whether these safer people are people
who did soccer.
Yeah.
Ah, okay. Yeah, okay. I don't know. And I'm trying to think if I could look. So I know the name of the boy. We could look at that. I'm not sure, like I could, you know, say anything conclusive, but, you know, we could definitely look at that. And this, I mean, this is sort of related to the complementarities, but not exactly, right? Because this is, you're changing your boyfriend, right? And now you're now pairing, are you matching now with a boy who did soccer? Yeah, let me think about that. That would be interesting if we could show that. Thanks.
But your other question was actually interesting, right? So we were saying that maybe there were other girls that were not treated that were getting the bad boys. So that's interesting. That's like a spillover effect or generally.
Exactly.
Be really cool to measure. Yeah.
We were really worried about that because I don't know if you've seen the Malawi work with like Sarah Baird, Burke Osler, like they're looking now at long-term impacts of younger girls who got these CCTs and UCTs. And though when they're young, they like delayed marriage and pregnancy and stuff, what they're finding in these small communities is that the kind of pool of boys, the quality decreases. So you actually end up with a worse match later because you didn't get married early, you know, and all the sort of good guys were taken. And like, that was one of the concerns here as well. Okay. So, all right, let me just wrap up. I want to say a few things that we were interested in looking at. So the psychology literature suggests that that decreased violence should result in higher locus of control. And we know that kind of locus of control is a key component of things like women's agency. And so at both baseline and endline, we did the, you know, for those of you who are familiar with locus, we did the Perlin mastery scale, which is like a 7-item scale of locus of control. And I think what's really interesting here is, you know, this panel A, we're back to our girls' data. And what this is showing you is that the goal setting intervention increases locus of control by about 0.1 standard deviation. And interestingly, we can't reject that the impact is at least as large as, you know, being assigned to the boys treatment arm. And I think what's like fascinating about, you know, this is that in both of these arms, we're seeing decreases in violence, right? And so again, you know, if we were psychologists, we would expect to see increases in locus. And in fact, we are observing that in the data. So very suggestive. I mean, but I think it's sort of fascinating. And then this goes to Katya's question about complementarities. We were very interested in looking at this issue, and I'll just quickly show you. It's sort of a mess here, but the complementarities would be, these coefficients here. And there's just really like nothing terribly interesting going on. But to give you an idea, I was telling you about how there's just not much room to move these things, because here, this is like a 5% mean, and we're already moving. So just, being in the boys treatment arm is moving this by like 3 percentage points, for example. Being in goal setting itself is like 5 percentage points. And so there's just, there's not much these additional interactions can do. The one place, I don't know. It's like here, for example, psychological abuse, which does have a mean of 9%, right? It's a higher mean. And you're seeing that the individual treatments aren't necessarily moving things. Here you will see this like negative coefficient, right? So there potentially could be a complementarity, though nothing is statistically significant here. But like overall, I think, our read of this table is there's just nothing, you would need kind of nice negative numbers here for there to be this complementarity, and we're just not seeing it in the data. We obviously, I've shown you everything for the balance panel, and you might be wondering like, hey, what do your attrition rates look like? And do we need to worry and let me just say you don't. I find this part of the presentation really boring, so I'm gonna fly through it. But there's just, we lose about like 18% of our girls between baseline and end line, but there's just nothing differential happening by treatment arm. And here is, we are kind of interacting treatment with some of these, outcomes of interest that we care about. And there's just nothing happening for the, that's differential by arm or by outcome for the girls. We do similar stuff for the boys. We're just not finding much. And so let me, so we can maybe have a few minutes of discussion. Let me just wrap up and say, kind of few concluding words in that, I think gender is ultimately about power relationships between, men and women, boys and girls. And here we've kind of focused on interventions that shift like one side of that relationship. And that these interventions very much targeted like opposite sides of the gender divide. And, and in fact, as I've shown you, it doesn't seem, at least in our data, that there's a significant interaction between the two interventions. I think like what's exciting about this study, and in fact, partly it's exciting because we were constrained by BRAC, but like we've basically provided evidence on two pretty effective and like very inexpensive and very scalable interventions that can reduce the IPV experience by adolescent females. And I think the other interesting thing about this study is changing gender relations at this early stage of adulthood could potentially, shift the trajectory of these individuals' lives, right? And I think this is, again, it would be great to be able to follow these individuals over time and sort of look at some of these longer run impacts. And as I mentioned earlier, I also think redoing some of this work in a higher violence setting could provide some important guidance on where we might want to scale these things up or where we might observe some interesting complementarities. So with that, let me thank you all for your questions and comments and open it up for additional questions and comments in the last few minutes.
Yeah, thanks, Manisha. We have around 5 minutes and a little bit more than 5 minutes. So if anybody has some questions.
Can I this is related to a question Alex asked earlier, and I recognize that you don't have much to say about it, but I'm just interested in what your sense is, which is like how much of a sense do you have that some of this could just be incapacitation of the boys are just playing soccer now, like there's, like you showed us the time use, and like, it seems like on both the boys and the girls side, they're spending less time together. And so the boys have something better to do than less violence happens.
Yeah, I think that's a fair point. I mean, I think some of it definitely is them just spending less time together, because you're absolutely right. The boys, you know, at Endline, boys are spending less time with girlfriends. They're playing soccer. I didn't show you this result, but the girls are also spending less time with boyfriends, and their offset is actually studying. So they're like hanging out with boys less and spending more time studying. I don't know. So here's where I'm struggling though. Is that like incapacitation, or is that just like my preferences have shifted, and that like, hey, I'm a guy. I realize I actually prefer to spend time on the soccer pitch playing soccer with my friends than I do hanging out with my girlfriend, right? It's just that like now I would rather be doing something else with my time. And I hesitate to call it incapacitation, because it's not that they're like in interventions being forced to be somewhere, right? They're kind of choosing to spend less time with their partners. And to me, that's like much more like behavioral change, or I don't know. I always like, we're economists and we don't like talking about preferences shifting, but like, it's that they're sort of choosing to do other things, right? I don't know what we want to call it. I still haven't figured out like a good term for it. But I don't think it's incapacitation, because they're making that choice, right? To be like, hey, and maybe for the guys, it's like, hey, my girlfriend now makes me wear a condom. I still like risky sex. I'd rather play soccer with my buddies, right? It might be some of that. I you know.
Yeah. No, I mean, like, I mean it not as a criticism at all. Like, I think it's an interesting possible channel, and I think everything you said is absolutely right. And yeah, I was very struck by what you said, that like, even, you know, whatever it was 6 or 8 months later, these boys are still playing more soccer. Yeah. That's a really cool result in and of itself, I think so.
Can I ask a question about the supply intervention and in general about contraceptives?
Yeah.
So do you just provide male contraceptives, male condoms specifically, or also female condoms?
Right. So exactly. So the contraceptives were provided to the girls only in the clubs, and they did provide both female condoms as well as male condoms. And we do actually see there's like no uptick in like anything. The only kind of small interesting uptick we do see is there's a slight increase in female condoms. And we were wondering if partly that's because the girls had never seen these things, and you know, they're like, hey, this looks interesting, I'm gonna, you know, take one from you. But yeah, both types of condoms were provided to the girls.
Okay, this is just personal curiosity. Do you ask whether the boys had preference for one or the other, or whether it was easier to convince them to have safe sex using one or the other of the two condoms, so the male and the female?
Oh, did we ask boys about female So we do ask boys about female condom use versus male condom use. And I don't remember. I mean, I feel like for self-use, like neither of those was terribly interesting. The interesting result was when we asked him about, like, you know, does your girlfriend use condoms? We saw we saw something. And it, you know, now I'm wondering, it is possible. I mean, I don't know, maybe she's getting the condoms from, you know, from Marie Stopes. I don't know. We haven't looked at that, but we could definitely look at that. I'm not sure. But for the boys themselves, for self-reporting, we're not finding any interesting thing on either kind of them saying, hey, you know, my girlfriend uses female condoms more, or I'm using, you know, male condoms more.
Okay, thank you.
All right, we are running out of time, so I think we can close it here. Thanks a lot, Manisha, for your talk. It was great to hear about your research, and thanks everybody for attending.
Yeah, thank you all for coming. It was great to be here.
Thanks.
Thank you. Thank you very much.